Welcome to tonight's webinar. My name is Allie Armstrong. I am a field marketing specialist for Axonics Therapy and will be moderating this webinar. This evening, Dr. Kriteman will be speaking about bladder dysfunction, the common symptoms, patients experience, and treatment options that may help you regain control. Without further ado, I would like to introduce Dr. Kriteman.
Thank you, Allie. I appreciate it. And thank you, everybody, for taking the time to join us this evening for us to talk a little bit about voiding dysfunction, bladder health in both men and women, something that I specialize in and spend a lot of time dealing with. So for those of you who can't see me, that's a picture of I like to say a picture of my younger brother who didn't have as much gray hair, but that's me on the left. And I specialize in general urology. Most of us do general urology, but I really do focus in voiding dysfunction in both men and women, and large prostate in males, and how that affects not only their voiding from a prostate standpoint, but also from a bladder standpoint. As far as my education is concerned, I did my undergraduate up in New Haven at Yale, then did medical school in New York City, and then came down here to Atlanta in 1993 to start my residency at Emory, and I've been down here ever since. So I want to thank Axonics for organizing this, and Allie, thank you, and the team there, and Mary for putting this all together. And I do find that this can be an excellent way for me to help educate a lot of people at the same time about this issue, about this problem. And then we can, do what we need to do moving forward as far as getting you into the office if this is something that you might be interested in. Just a few slides on safety. I do have to put these up, and if anybody really wants to see these, they are up on the website, and I tend to go through these pretty quickly because it's a lot of legal mumbo jumbo. But we have put them up, and we've gone through our safety slides. My English Cream Golden has joined me for the talk, and that's quite all right. That's not a problem. So here we are, slide one. And, as we know, bladder symptoms really can disrupt your life. And, patients, it doesn't only disrupt the person who's having those bladder symptoms, but it also disrupts their spouses. It can disrupt the family and friends. You're in a car and you're driving and you constantly have to make stops because you have to use the restroom. You get up from movies, or you get up from being in church or synagogue, and because you have to go to the bathroom. And then I always like this last one here, because somebody who's always looking, wherever they go, to make sure they know where the closest restrooms are, because they have that urgency and that frequency, those symptoms that really cause them to do that. You're not alone. And because I specialize in this, I see so many patients in my practice who have these bladder symptoms, this overactive bladder type of situation. And what I really want to do is make sure that everybody kind of understands the terminology that we use. I want to make sure that we're all sort of on the same page as to how we speak about bladder symptoms. And then we can sort of get into the specifics of how we can treat those bladder symptoms. But this woman, Jill, who's in the marketing campaign for Axonics, was a real patient, and she tells her story. She's been in commercials for them, and she's somebody who had lots of issues with overactive bladder and leakage, and finally did something about it, and she had an implant done and has done remarkably well. Overactive bladder is incredibly common across the United States. We have over 50 million people that are diagnosed with overactive bladder. There's another at least 19 million people who suffer from fecal incontinence. And so there's a lot of folks out there. And this point down here, I think, is very important, which is only about half of those folks, 25 million, ever seek treatment. And they have severe symptoms. There are folks who are wearing, diapers all the time. They're wearing pads. They feel that, or at least they think that this is kind of a normal part of aging. And that's something that we have to get past and make you understand that that isn't the case. And there are lots of things that we can do to help you and help your situation. We're going to talk a little bit about stress urinary incontinence. That's what SUI means. Stress urinary incontinence is very common. We see it in about 1 in 3 women that at some point in their lives will suffer from this. And stress urinary incontinence is different than urge incontinence or overactive bladder, wet incontinence, and we'll talk a little bit about what those differences are. So why don't we go right to sort of what happens with the bladder. And we have two cartoons here. And in normal bladders, we kind of break down what happens with the bladder and with the urine into two stages, the storage of urine and then the emptying of urine. And so the kidneys make the urine. The urine constantly drips down these two little tubes here, and they drip down to the bladder. And as the bladder fills, this big muscular bag has to be able to relax, and it has to be able to, contain and hold all that urine. And so when the bladder is completely empty, it's really sort of squeezed shut. And then it's important that that bladder has the ability to stretch. And as we get older in general, we lose elasticity in all of the muscles and joints and ligaments in our body. And the bladder loses some of its elasticity as well. In men who have big prostates and their bladders have to work extra hard, pushing urine through that prostate, those bladders tend to get more rigid and less elastic, less compliant just from doing that. So very important that the bladder can relax so that it can accommodate the urine. And then when it empties, it's very important that the sphincter relaxes at the same time that the bladder starts to squeeze to push urine on out. And if there's issues with the sphincter, sometimes that can cause the stress incontinence that we'll talk about. Sometimes sphincters don't relax very well, even when the bladder's squeezing, and that can happen in patients who've had strokes. That can happen in patients who have other problems with their lumbar spine. And so there are lots of issues, and this tends to be very much more complicated than these two cartoons here, but we do basically break it down into, hey, that bladder has to expand and hold urine, and then that bladder has to empty by squeezing and pushing urine out through that sphincter. So lots of different problems that we see that can contribute to overactive bladder and leakage. Overactive bladder itself, by definition, is the sudden urge to urinate in patients who are unable to hold or control that urine. Urinary retention is somebody who can't empty their bladder, difficulty urinating and incompletely emptying the bladder. As I mentioned earlier, sometimes that'll happen in patients who've had strokes and the nerves and muscles going to the bladder aren't working very well. Fecal incontinence, involuntary loss of stool, and then the stress incontinence happens when patients leak, when they cough, sneeze, when there's increased pressure from the abdomen pushing on the top of the bladder. And that can be exercise, that can be, coughing, sneezing, laughing, jumping up and down, can all cause stress incontinence. And what's interesting is we have lots of patients who have overactive bladder, also with stress incontinence. We call that mixed incontinence. And they can also have some fecal incontinence as well, especially if it's a nerve issue that's causing the problem. So let's talk about each one of these individually. Overactive bladder, or OAB, is the frequent urgent need to empty the bladder. Oftentimes that results in unintentional loss of urine, and we call that overactive bladder wet versus overactive bladder dry. So we break this down into other definitions. Urinary frequency, if we talk about, well, what is frequency? Usually by definition, it's voiding 8 or more times per day. But I'll be honest with you, the more you drink, the more you're going to have frequency. So we have lots and lots of patients who come in, and when I get down to it, after we sit down and have quite a long conversation, it turns out that the patient's drinking 3 or 4 gallons of water every day. And guess what? That's going to cause urinary frequency, because what goes in has to come out. So, a lot of lay people, a lot of our patients, and even a lot of physicians seem to think that drinking lots and lots of water is healthy for patients. And I always like to have the conversation with my patients that if you drink too much water, that's going to overwhelm your system. That's going to make you go too frequently. And really, it's going to make your kidneys work overtime. And so there was an article, I tell the story all the time, an article in 1941 or 42 in Reader's Digest that said a patient should drink 8 glasses of 8 ounces of water a day to be healthy. Nobody really knows who wrote that. Nobody knows where they came up with those numbers, but most patients have a normal thirst mechanism, and that thirst mechanism tells you when you need to drink more water. So if you're dehydrated or underhydrated, you will be thirsty, you will go and drink. I tell patients, please don't count the number of glasses, please don't count the volume or add up the volume of fluid that you're taking, because that's not a healthy way to be. It's healthy to be hydrated, it's not healthy to be overhydrated, because when you do, it causes more urinary frequency. The second point is urinary urgency, which is the sudden urge to urinate that's difficult to control. Then that moves on to urge incontinence when you can't control it and you lose that urine. And then nocturia, by definition, is frequency at nighttime. That's getting up 2 or more times at nighttime. So those are just phrases that we use. So we're all talking the same language. Those are definitions that we use when we're dealing with this problem. So what is stress incontinence? As I mentioned earlier, if you have too much pressure that's put on the bladder, on the outside of the bladder, the urethra is not able to stay closed. So if the pressure here overwhelms the closing pressure of the urethra, then patients leak urine. And that tends to happen as the muscles and the ligaments down here loosen. We see that more often in women than we do in men. We see it in women who've had lots of large babies. We see it in women whose muscles down here have lost some of their ability to hold that urethra closed. So physical activity, coughing, sneezing, laughing, they increase that intra-abdominal pressure, as we mentioned. This pushes on the bladder, which overwhelms the urethra, and then patients leak some urine. So by definition, that is stress urinary incontinence. So how does that impact quality of life as far as our patients are concerned? Well, it certainly can limit you from a physical standpoint, limiting participation in physical activities because you're afraid you're going to leak urine, whether it be from a stress urinary incontinence or an urge incontinence. In social situations, reducing social interactions, altering travel plans. Psychologically, patients have lots of guilt. They can be depressed, loss of self-respect, fear of accidents. They're worried that they're going to have stains on their pants that people are going to be able to see. It's going to happen in, the most inopportune times, and that can really affect patients from a psychological standpoint. Certainly sexually, it can affect you. From an occupational standpoint, patients don't want to go into work. I think patients who work from home have really, because of the pandemic, it's actually helped them not have to be in those situations, but that's really not a way that we want patients to live when there are so many good answers out there to help you with your urge incontinence and your stress incontinence. And then domestically, wearing pads or diapers, special bedding, precautions with clothes, wearing dark colored clothes because you're afraid of, having wet spots and things like that. So those are just 6 points that really show how this condition can affect the quality of life. So the condition really is not a normal part of getting older. A lot of people see their mother or their grandmother having gone through similar situations, and they say, well, I'm getting older, that's now my turn. And that's not the case. And there were certainly lots of things that we can do to prevent that. It's not just part of being a woman. It's not just part of being a man who has a large prostate and having issues with the prostate. And then it's not caused certainly by anything that you did. This is not your fault. It may be partly in your genetics, but that's something that none of us can really control. So this isn't really anything that you did to start to cause that problem. The good news is there are lots of different treatments to help patients regain control of bladder and bowel issues, and we're going to talk a little bit about those. So at Georgia Urology, and for those of us who specialize in this problem, we like this little pathway that we have here, this 1, 2, 3, 4 type of thing, because it gives patients an idea of, what's their course going to be when they come and get evaluated for overactive bladder, urinary incontinence, stress incontinence, urge incontinence. So very important that you realize right up front that those of us who specialize in this is kind of what we want you to realize, that we're going to go in, number one, we're going to consult with a doctor. We're going to talk about your symptoms. We're going to talk about how often you leak, how often you go during the daytime, some of the treatments that you may have, tried in the past, and then what our treatment options are, moving forward. So as far as initial treatment, if you've not tried medicine, a lot of times we're going to do some prescription medication. There are different types of prescription medications that we have now that were not available 3, 4, 5 years ago. And so the old style Detrol and Ditropan medications, which can be very useful, those are sort of the first generation medications. We have second and third generation medications now. Certainly lifestyle changes, just something as simple as not overhydrating, can be very helpful in patients, or not drinking for several hours prior to bedtime. I have a lot of patients who will keep water on their bedstands and keep filling it up all night long, and they keep wondering why they get up all night long, because they keep drinking that glass of water. There are bladder training exercises You know, some people will call them Kegel exercises, but not just Kegels. There are pelvic floor physical therapy exercises that we have patients do that really can help the overactive bladder. For urinary retention, we have different medications that can help with this, as well as behavioral management. For fecal incontinence, there are things that can be done for that as well. Once we've done our initial treatment, our prescription medication, our lifestyle changes, let's say if it's for overactive bladder, we like to go and have a follow-up with the physician. It says doctor, but in my case, I work with a team. I work with my mid-level. For those of you who know me, I work with Clint as my PA. I also have my MAs that work with me and are very familiar with helping our patients, you know, figure out, okay, well, that medicine that we tried you on over the last 3 weeks, that doesn't work. So this is going to be our next step. So if we don't see great results from what we did on step 2, don't give up. There's lots of other things that we can do, and that gets us to number 3. So for number 3, that's when we start talking about, for overactive bladder and leakage, Botox. We start talking about percutaneous tibial nerve stimulation. That's kind of like the acupuncture treatments that we do. And then finally, the sacral neuromodulation, which was probably the most successful thing that we can do for this problem. For urinary retention, obviously, if patients can't void at all, if they have a catheter, we try to get catheters out and teach them intermittent catheterization. Also, sacral neuromodulation can be helpful for that problem as well. And then for fecal incontinence, when that doesn't work, sacral neuromodulation can help with that. But then if surgery is required, I would send you to see somebody who specializes in that type of surgery if the sphincter needs to be repaired. So what are some of these advanced therapies that we just talked about? This is the acupuncture. I call it the acupuncture. It's percutaneous tibial nerve stimulation. Basically, what we do is we put a little acupuncture needle down by the ankle bone, and we stimulate this nerve that's running up the inside of the leg. This is the posterior tibial nerve. And this nerve comes in to the back and to the spine in the gateway where the nerves come out and go to the bladder. And what that does is it helps to down-regulate the nerves that are coming to the bladder just by affecting these nerves here. So it's done in the office. There are 12 weekly sessions. Each session takes 30 minutes. We do once a week. Medicare says we have to do 6 sessions and then reevaluate the patient and see how well they're doing. If patients are doing well, we do the second 6 weeks, and then we put patients on a maintenance plan. And when it works well, it really does work well for patients, and it has absolutely no side effects at all. So it doesn't dry out your mouth. It doesn't cause you to have any funny taste. There's no upset stomach or anything like that. You don't feel this as this is being done, this treatment, but it really does affect that bladder and the nerves coming out to the bladder quite well. Botox is something else that we can do. People say it's like taking the wrinkles out of the inside of the bladder. Everybody's familiar with Botox when we inject it in somebody's wrinkles on their face, but this is for the inside of the bladder. I was actually involved in the initial trials that we had when we did Botox, and we did those trials probably about 17 or 18 years ago now, injecting Botox in the base of the bladder. We don't inject it anymore all over the bladder. We really focus on the bottom of the bladder. And it can be very useful in reducing urgency, frequency, and urge incontinence. It's done in our little surgery centers. I don't put you to sleep to do this. I can numb up your bladder fairly well. And it usually, the Botox wears off every about 5 to 7, 8 months. And so that means if you get good results from Botox, we usually have to re-inject it every 6 to 8 months to keep that bladder sort of calm and not having that frequency, urgency, and incontinence. So what we've come to finally here is a sacral neuromodulation, SNM. And what we're going to do when we do this is actually stimulate directly the nerves that are coming out of the spine and going to the bladder. And that nerve root is called the S3. S stands for sacrum, S3 nerve root is the third one down. And when we stimulate that in a specific way, it really can do a remarkable job of managing that bladder, but also managing the colon when we're dealing with fecal incontinence. So it's the same gateway, that S3 down here, that same gateway that we try to stimulate when we do the acupuncture down on the ankle, but this is really a more direct way to get to that nerve. So it's the nice thing also about sacral neuromodulation is that Medicare and all insurances require that we do a trial. We do a test of this to see if it's going to work. And so this is the only time you get to sort of test drive something to see whether or not it's going to be useful as far as a procedure is concerned. And so what we do in my surgery center is I bring you in, I numb up your back, I lay you on your belly, I numb up your back, and I'll actually put a tiny little wire into that S3 foramen where we saw that on that cartoon, and we stimulate that nerve coming out of your back. We know that we're at the right nerve because of the responses that we get. When we're happy with where that is, we tape everything on your back and we send you on out. And for 3 days, typically, we test to see how well that's going to work, and it works immediately. So this isn't like a medicine where you need a week or 2 weeks to see if the medicine is going to work. This is going to really help and work in the first day or two to reduce frequency, urgency, and leakage. And I'll be honest with you, in doing all the things that I do, nothing is going to reduce that urgency, frequency, and leakage as well or as much as sacral neuromodulation does. If the trial works well, if we see a significant improvement in your symptoms, we like to see at least 50% improvement, then we go and we do a permanent implantation. For the permanent implantation, I do tend to put you to sleep for that. And everything is on the inside. So people are always worried that they're going to have wires coming out of their back. Everything's on the inside. And it really is an excellent, excellent way to take care of that urge incontinence and that frequency and that urgency. Just real quickly, some of the treatment options for stress urinary incontinence. Remember, stress incontinence is the cough, sneeze, laugh. We do pelvic floor exercises, and I've got some great women that work in our physical therapy group that come to the office and help patients really learn how to do appropriate Kegel exercises and levator ani complex exercises, which are the muscle groups that really keep you dry and keep that sphincter tight. You can do urethral bulking, which we have down here on the bottom, and we'll talk a little bit about that. And then we can put in slings that help patients, really who want to be very active and help them stay dry when they are active. So those are kind of the treatment options that we use for stress incontinence. We talked a little bit about lifestyle changes and teaching folks the pelvic floor exercises. Most commonly they're known as Kegels, but it's a little more complicated than that. We really want patients to make sure that they are doing the exercises correctly and that they are contracting the right muscle groups to really strengthen those muscle groups. So we really help patients when we do pelvic floor physical therapy for them to do that. When we put in slings, those are little hammocks that we will put below the urethra so that urethra, when you cough, sneeze, laugh, it can't move down, straighten out, and leak the urine. The sling, if you're just sitting there watching television, doesn't do anything. It only really comes into effect when things get pushed down and that urethra tries to move down. I think that slings are an excellent way to take care of lots of different types of stress urinary incontinence. I think most of the slings that are made of mesh got terrible press years ago. Most of this mesh is made of a Gore-Tex mesh that we use for everything in the body, hernia repairs and all sorts of other things. And 99% of patients really do quite well with that mesh. And some patients, 1% or less, will have some issues where their body doesn't like the mesh, doesn't like the Gore-Tex and tries to spit it out. But really, when we put in slings with 17-year follow-up, 80 to 90% of patients show success. The mesh never goes away. It doesn't dissolve. It doesn't weaken. And so if you get it in the right place and it works well for those patients, it should last basically forever. And so slings can be a very good way for our patients to get good results as far as stress urinary incontinence, but it's a surgery, it's an operation. When we do bulking agents, and the way urethral bulking agents work is we actually will inject little pillows around the urethra near the bladder neck on either side of the bladder neck just to give it a little bit more support. So if you think of this bladder neck and urethra as a donut, we want to make that donut hole a little bit more compressed so that there's less urine that's going to leak out. This tends to be a very easy procedure. See if I can go back here. Yep, a little easy procedure that I do in my little surgery center. I can do it with sedation. Takes about 5 minutes and really can be successful in patients who have a minimal amount of stress urinary incontinence, who are older, who I don't necessarily want to put to sleep for a sling. And then I have a lot of sling patients who only get 80% better, and they wonder if I can get them 95 or 100% better. Sometimes I'll do a little bulking on the inside. Their sling sits lower than that, and sometimes that can help them as well. So urethral bulking really can be a good way to help patients with their stress urinary incontinence as well. So I want to talk a little bit more about axonics therapy. This is the sacral neuromodulation that I mentioned earlier. It is recommended for patients to restore normal control of both bladder and bowel. So I can use it in my patients who have overactive bladder, the frequency, the urgency, and the leakage. I can use it in patients who have urinary retention to try to remap those nerves that go to the bladder and help those nerves to stimulate the bladder better. I can also use it in folks who have fecal incontinence or who have a combination of fecal incontinence and overactive bladder. And so really can work very well for those patients. So how does it work? Well, if I can stimulate those nerves appropriately, it will restore normal communication between the brain, the brain stem, the spine, and then the nerves that go to the bladder and the bowel. And if we can do that, if we can restore that normal communication, it results in improvement in the symptoms, and in most cases, remarkably so. And so what do we do for the first steps? As we talked about earlier, the first step is a simple trial. That's usually done, like I said, in my little surgery center. You're not put to sleep for that. I do numb your back up and put a little lead or a little wire into the spine of that S3 foramen. And that's what allows us to stimulate that nerve and to make sure that that nerve is working appropriately. And as we talked about earlier, we do that for a 3 to 5 day period of time as the trial. You come back into the office, we take those tiny little wires out. They're almost the thickness of a human hair, so you don't really feel it as we take them out. And we see, okay, how do we do? Did we do 20% better? Did we do 50% better? Did we do 90% better? And I will tell you that the vast majority of my patients, well over 80–85% of my patients, show significant improvement, especially for the overactive bladder, urgency, frequency, and leakage, whether that be for the bladder or the bowel. Urinary retention, especially if it's due to nerve damage, such as a stroke or such as lumbar spine issues, the success rate is still better than nothing, and we see improvement in a lot of those patients, but it's certainly not as high as folks who just have the overactive bladder. Once we have done the testing phase and we find that patients have done well with the test, they've got over that 50% improvement, then we talk about putting in a permanent implant. And I really refer to this as a pacemaker for the bladder. We're going to teach that bladder how to empty better and how to be more elastic and be more compliant and hold more urine and have less leakage episodes. We can do that with two types of systems. One is a permanent battery system, which is called the F15. And that's what it actually looks like. It goes underneath the skin. I put it in a little area underneath your fat pad on your rear end. And with the battery technology that we have now, and Axonics really broke into this game because of their battery technology, most of our patients are getting between 10 and 20 years of life out of that battery. And that's pretty remarkable compared to what they used to be years and years ago. We also do the R20, and this is a rechargeable system. It's a little bit smaller as far as the battery generator system is concerned. Typically, most of our patients have to recharge between 6 and 10 months. So every 6 to 10 months, you have to recharge it. And depending on what your levels are, we're getting 20 years plus out of this battery as far as how long it's going to last before we have to take it on out. This gives you an idea of what the remote control really looks like. It's like a key fob for your car. And this is what helps you to change your programs and go up and down. And quite frankly, most of our patients, once we get things set, never need to do this. This is something that's constantly working. So some people think you got to turn it on or turn it off when you need to go to the bathroom. You don't. This is something that's constantly talking to the nerves that are going from your spinal cord to your bladder and making sure that they're doing the correct thing. So most of my patients put this in their bedside drawer and don't even mess with it and don't need to mess with it. That, again, is the pocket control. I do not encourage you to put your keys on this and carry this around all the time in your purse or, in your pocket for the guys that are out there, because you don't want these buttons getting pressed, and there's just no reason to do that. So keep it at home, keep it in a drawer somewhere. What's very, very important with the newest units that we have is that these units are fully compatible with body MRIs. So the older units, when I was putting these in 15 years ago, they were not compatible. And in patients who absolutely have to have an MRI, we used to have to take the units out so that they could go get their MRI. So the implants now that we put in, they do not need to be removed. They are approved for 1.5 Tesla and 3 Tesla full body scans. That's going to encompass pretty much everything that's out there. So don't be concerned if you have your axonics put in that you won't have, you won't be able to get MRIs if you need MRIs. So what are our numbers look like? So overall, what we find is 93% of patients achieve clinically significant improvement in incontinence symptoms at 2 years. And that means that they were really happy and they were doing much better from a leakage standpoint, from a pad use standpoint, from a getting up at nighttime nocturia standpoint. So we really see great results with that. 2 years after the implant, 94% of the patients are satisfied. 93% of patients would undergo the therapy again and get the same expected results. And so this patient that has come up several times, Jill, who had this done, and again, she's got a commercial out there that's been aired at different times in different sporting events, but she was somebody who was miserable. And at age 45, she finally had an implant put in, and it really did change her life and make her kind of get back to sort of normal lifestyle. I want to talk real quickly about Bulkamid. This is the bulking agent that Axonics has available to help patients with stress urinary incontinence. Kathy is another one of their real Bulkamid patients. It's a minimally invasive non-mesh alternative to treat stress urinary incontinence. It's soft, it's water-based, it's a gel that we inject, and it really should last for quite a long period of time.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So what we do when we inject that is we actually look up into the urethra with a small little scope, and we inject this little pillow, as I talked about earlier, on either side of the urethra. This is the donut that I referred to. So we inject here, 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 and here. Bulkamid, as we talked about, what it does is basically take that donut hole and give it some more support, so that when patients have increased pressure on the bladder, pushing that urine, they have less leakage because they have more bulking and they have more support at that portion of the donut hole as it comes right out through the urine, and really can work quite well for a lot of my patients, especially those patients who don't necessarily want to undergo anesthesia, or patients who have prior procedures done, bladder lifts and things like that. This can be a very good way to improve their stress incontinence without having to do very much surgery. It's similar to facial fillers. They remain in the body over time. They don't dissolve. And so once I put this in, it really can help that. And I've come back in several patients when I get them 80% better and they say, gosh, can you get me another 15%? Sometimes I can add Bulkamid to these little pillows to give them even more support. And that can be very helpful. So safe and effective. 92% of women are cured or improved after Bulkamid. It's a simple procedure. I do it in my little surgery center with minimal amount of sedation, and then long-lasting results after we've done that. So this, I think, is the last slide. I'm going to leave this up. And if you want to take the next step towards symptom relief, if you're tired of taking medication like, the Detrol or the Ditropan or the Vesicare, Mirbetriq, Gemtesa, these are all medications that we use to help with overactive bladder. What we find, unfortunately, is that many patients who've been on medications, those medications either lose their efficacy, they have too many side effects, or they're too costly. And as a result, patients drop out. They don't use that medicine anymore, and they don't seek refills, and they just put up with their symptoms. And so there are other things that we can do. And if you've, been watching this whole talk, you'll realize that there are lots of different things that we can do. And my goal and my team's goal is to get you to a place where you're satisfied with your symptoms, that you don't have to put up with things any longer, and that you're, better off than you were when you started the journey of dealing with your bladder symptoms. So again, if you do want to try to get in and talk about this with myself, with my team, with Clint Manley, who's my PA, go ahead and scan on that screen, and that'll give you an availability to get an appointment so that we can talk about that. I did get an earlier question that somebody had forwarded to me, which was a very apropos and interesting question. It was from a male patient who has an enlarged prostate, and most of his symptoms are what we call storage symptoms. They're the bladder symptoms. So his biggest issue is his urinary frequency, his urinary urgency, and his getting up at nighttime, and even sometimes where he can't get to the bathroom fast enough, and has leakage because he can't get to the bathroom fast enough. And his question really was, is this a bladder issue or is this a prostate issue? And my answer to that question is yes. It's actually a bladder issue and a prostate issue. Most men who have enlarged prostates, that enlarged prostate makes the bladder work harder. And if it works harder over time, the bladder, as we talked about at the very beginning of the talk, gets stiffer, it gets less elastic, it gets more muscular because it has to create that more pressure to push through the enlarged prostate. And that's actually not good for the bladder. It causes that bladder to have more urgency, frequency, and leakage. So in most men, in about 70 to 75% of men, if we open up that prostate, if we debulk that prostate, if we make that donut hole larger so that the bladder doesn't have to create so much pressure, 75% of the time, those symptoms improve. The urgency, the frequency, the nighttime frequency, and the leakage. And so 75% of the time, I can cure your bladder symptoms just by taking care of your prostate. And it doesn't have to be a TURP, and it doesn't have to be a laser. As long as we do something to decrease that pressure, those patients do well. 25% of men have an intrinsically overactive bladder, so I can treat your prostate and they'll still have those symptoms. Or sometimes they've done permanent damage to the bladder, and as a result, even after I do a prostate procedure, they still have too much urgency, frequency, and leakage. And so I think it gets a little bit more complicated in the male patient because the prostate is there, and much less so in the females who don't have prostates, but we treat it somewhat similarly once we figure out exactly what the issue is. So hopefully that answers that question. And what I'll do now, Allie, is I'll open it up to any of the questions that have been typed in or have been asked, and hopefully we can move through that.
Yeah, thank you, Dr. Kriteman. It was a pleasure hearing from you and your experience with treating patients from these conditions. You definitely touched on this one, Dr. Kriteman, but the first question is, how do I differentiate whether my symptoms are a result of overactive bladder or enlarged prostate? Seems like quite a bit of symptom overlap between those two conditions.
Yeah, that's a great question, and it's sort of, I guess, akin to the question that was forwarded to me initially. You need a workup is the real answer. So we need to talk about those symptoms. We need to quantify those symptoms. And then we have ways to work patients up, to evaluate how much of the situation is a bladder situation versus a prostate situation. So that usually requires some sort of measurement of the pressures in the bladder. Nowadays, for our male patients, we do a voiding test called a urocuff test. We actually come in and you pee in a special urinal. There's a suction cup that's on the end of the penis, and it will measure the back pressures, how much that bladder is actually having to work, which tells me how much of the issue is a bladder issue versus a prostate issue. Getting an evaluation of the urethra with a cystoscopy and then measuring the size of the prostate are all part of my workup for those patients who have enlarged prostate. Once I have that information, then we sit down and we talk about, okay, how much of this is due to the prostate and we need to treat the prostate, how much is due to the bladder and we need to treat the bladder, and how much is overlapping. And a lot of times they do overlap, and we kind of need to do a little bit of both. So the answer is we need to get you worked up. And once we do the workup, then we sit down and we talk about the results and what we can do to make things better.
And are all of these procedures covered by Medicare?
Yes, they are. So all of my workup procedures are covered by Medicare. And then all of the procedures that we presented in the slide deck today are also covered by Medicare, whether it's Botox or sacral nerve modulation or percutaneous tibial nerve stimulation or Bulkamid. These are all things that Medicare cover. What's the nice thing, on the sacral nerve modulation portion, the bladder pacemaker port, is Medicare says, well, wait a minute, we really want you to do that test drive first. We want to make sure that it's going to work before we have you go and put in a permanent system. And like I said, you can't test out your new, if you go and you have a knee replacement, if you can't have you can't test out a fusion of your lumbar spine, there's so many different things that you can't test to see how well it's going to work. But Medicare really does make sure that this is going to work before we go and we do that.
Thank you. This is a good one. Are you currently taking new patients?
Oh, absolutely. Yes.
Okay, this one's a little specific, which you kind of touched on, but how long after incontinence post aquablation should a patient consider S&M? Now, 2 months post-op, nocturnal and inconvenience during daily activities.
Yeah. So, that's a good question. And it really depends on a lot of different factors. So after we do a debulking procedure, after we do a resective procedure, whether it's an aquablation or a green light laser, or if patients have had TURPs where we really open up that prostate, it can take up to 6-8 months for bladders to sort of recalibrate and reset, meaning that they'll have less urgency, less frequency, and less leakage. And so I tell my patients, after we've done a procedure like an aquablation or other resective procedure, we need to give it some time to see whether or not that bladder is going to reset. The other factor that plays a role in that is kind of what the bladder was like before the procedure was done, like the aquablation. So patients who are already having lots of urgency, frequency, and leakage beforehand will tend to have more issues immediately post-operatively for the first couple of weeks and even the first couple of months. And so those patients tend to have, more of an issue for a longer period of time. If you were somebody who came to see me, or if we did your aquablation and you were having significant problems 3-4 months after the procedure, I would work you up a little bit to make sure that everything looked good from the prostate standpoint, meaning we took the prostate out of the equation. And if it looked good, I would offer patients at the 3-4 month mark, their first trial of doing something like sacral nerve modulation. So I wouldn't probably do it before the 3-month mark. I'd want to give that bladder a good college try of fixing itself and recalibrating. But after the 3-month mark, I would be willing to give it a test to see how well we could get that frequency, urgency, and incontinence improved.
I like this one. Does the permanent sacral nerve modulation unit interfere with any physical activities?
No, absolutely not. So we do like patients to take it easy. I usually like patients to take it easy for the first 4 to 6 weeks after implantation. And that's mainly because I want the lead that's going into your S3 foramen, that hole where the nerves come out. I put a lead right in there, and I want that to sort of get stuck in place. I want that to scar into place before I let you go and really get very active, because if you're very active and running or swimming or twisting and turning, sometimes that lead can get displaced, and I don't want that to happen. So I usually limit patients for 4 to 6 weeks after the implantation, but after that, go to it. Go swing a golf club, go swimming, go ride your bike. It'll have no ill effects on your activity level at all.
Do you recommend diet changes first before surgery? Example, spicy foods, citric acid, caffeine, sugars, etc.
Yeah, everybody's different, and there's certainly no doubt that there are certain foods and drinks that can affect the bladder, that can cause the bladder lining to be more irritable and cause patients to have more urgency, frequency. I think if you can get by with just changing your diet, and that's, significantly improves your storage symptoms, then by all means you should do that. We encourage that for our patients. And a lot of times that can be helpful. It depends on whether it's helpful enough. Has it improved your quality of life enough that you don't want to move forward with something, a little bit more advanced? And if that's the case, that's fine. So yeah, I think that is very helpful.
I'm currently taking medication for my OAB. Is this something that I'll have to stay on my whole life?
Yes. So the medication that you take, think of it as blood pressure medicine. Your blood pressure is elevated. You stay on blood pressure medicine for your entire life to keep that blood pressure controlled. It's the same thing with overactive bladder medication. You're trying to keep that bladder controlled and downregulate those nerves and those muscle bundles that are in the bladder. So if your medicine's working, you can't stop the medicine because you'll revert back to the way things were before.
And can I still have children after having Bulkamid?
Yes.
And is there an age limit on these procedures?
Good question. I don't believe so. That's a great question. I've put in sacral nerve modulation in patients up to over 90, and I haven't had any issues that I'm aware of. So, somebody on the line from Axonics, if you know differently, I don't think that there is an upper age limit, and probably the lower age limit is 18 or maybe 14. just because it wasn't necessarily studied. But no, it shouldn't affect you from childbearing standpoint, whether you do sacral nerve modulation or whether we do Bulkamid. Neither of those should have any impact on you from a childbearing standpoint.
And can axonics or anything else help after prostate cancer surgery and radiation?
Yes. So absolutely. Radiation will have a negative impact on patients from that radiation's effects on the nerve endings at the bladder neck and inside the bladder itself. And so I have many, many patients who are post-radiation from prostate cancer or radiation from colon cancer or rectal cancer. And anything we can do to downregulate those nerves and make those nerves work more properly will help that problem. So I've done quite a few male patients who are post-radiation because they have storage symptoms and leakage. So good question.
Is the procedure painful?
I assume we're talking about sacral nerve modulation.
Yeah.
Again, it's done in 2 steps. The first step is done without any general anesthesia. It's done with local. So I numb you up as far as your tailbone is concerned. And most of my patients are pretty comfortable. You may feel a little bit of a pinch every once in a while, but the vast majority of my patients are not in any significant pain. When we do the permanent implantation, I do use general anesthesia, so it's not painful at all. And then afterwards, there's a minimal amount of discomfort from where I put that little battery generator. Not so much that patients require any narcotic pain medication, and that discomfort usually improves over the first week or so after the procedure.
And do you treat for pelvic prolapse?
So that's an entirely different problem.
Someone wants to know, and it's anonymous, so I can't
Yeah,
respond.
no, I get it. So, pelvic prolapse is a different issue that usually requires different treatments. I do evaluate and treat pelvic prolapse, but nowadays with robotic surgery and all, I would tend, for me personally, I tend to refer that to one of my colleagues who does robotic surgery.
And I'll get to this last question. Does being a diabetic increase urinary incontinence?
Yeah, diabetes has a negative impact and a negative role on the way bladders work, the way stomachs work, and it's the same type of muscle and the same type of innervation. So diabetics tend to have a little bit more urgency frequency for variable reasons. If you keep your sugars under really good control, it helps to minimize that negative impact. So folks who are spilling sugar into their urine because their blood sugars are running too high, can have more urgency frequency leakage. And then honestly, some of the newer medications that pull sugar out of your bloodstream and put it into your urine to excrete it that way, a lot of those patients also have worsening symptoms just because their bladders do not like all of that sugar in the urine. So overall, yes, diabetics tend to have more problems with urgency, frequency, and leakage.
And that brings us to the end of this evening's webinar. If you have any questions or would like to schedule an appointment, we have several ways to help you do so. You can scan the QR code. For those of you who haven't had the pleasure of doing a QR code, it's the easiest way to schedule an appointment. Here's how it works. On your compatible Android phone or tablet, open the built-in camera app, point the camera at the QR code on your screen, tap the banner that appears on your Android phone or tablet, and you will be directed to our scheduling window. Here you will be asked at the reason for visit, to which you will type webinar/mailer for access to appointments with Dr. Kriteman. You can also visit the Georgia Urology website directly at www.gaurology.com and click on the orange schedule button. When prompted for the reason for your visit, please type in the word webinar and mailer. Thank you again, Dr. Kriteman.
Oh, you're welcome. I appreciate the time, and I appreciate everybody out there taking the time to join us for the webinar. It's an important problem. Don't belittle it. I know sometimes physicians do, but there's a lot of things that we can do to help and make your situation better. If you're not really adept at QR codes or, websites or all, go ahead and just call our office and say, hey, I was on Dr. Kriteman's webinar. I'd like to get an appointment with either myself or Clint, my PA. Clint's been with me for almost 15 years. He's my right-hand man. So don't necessarily hold out to get an appointment only with me. He's been doing it a long time with me. We're very simpatico. And since I'm in the operating room pretty much 4 days a week, it's sometimes easier to get in to see him before you can get in to see me, but we act as a team. So Allie, thank you for running this, and thanks Axonics for putting this on. And I hope everybody learned something tonight. So have a good evening.
Thank you.